Hello, this is Dr. A. I've got a clean chem review video for you on nutritional assessment. We're going to do an overview and look at all the macromolecules. Alright, let's talk about the nutritional care process. It's a systematic approach that is used by registered dietitians to identify, diagnose, and treat nutrition-related problems and disorders. There are four components of the nutrition care process. First is nutrition assessment, then there's nutrition diagnosis, 3-day nutrition intervention, obviously done by registered dietitians, and then nutrition monitoring and evaluation. So for the nutrition assessment, it's a systematic process of obtaining, verifying, and interpreting data, lab data is part of it, to make a decision about the nature and the cause of the nutrition-related problems. It includes, at a minimum, the measure of height and weight, and from those two measurements, you calculate the BMI. But of course, nowadays there are so many lab tests and so many things that can be done that getting more than that is obviously a very good idea. So the A through E of nutrition assessment. So A is anthropometric, or body composition measurement. So this is where you would at the very least get the BMI, that height and weight. But there are machines now too that can read your body composition, even in all the different areas, and see how much muscle you have, how much fat, and all of that, how much water. And so that would be in this type of body composition measurement. B is for biochemical analyses. So this is where you would get all your lab tests and, assessment of the different vitamins and stuff like that we're going to talk about. C is for clinical examination for by a physician or another provider. So again, just looking the person over, some of the things they may look for. It might be palpate the thyroid and other things like that to look for things that might be causing underlying issues there and the nutritional problems. D is for dietary analysis and assessment to determine what the usual food intake is. It's usually done by a registered dietitian and usually involves like food logs, diet recall logs, and that kind of stuff. So you can use, a patient could use an app, or even simply remembering what they ate in the last 24 hours, or use an app like MyFitnessPal, or you can now track stuff with Apple Watches and Fitbits and stuff like that. So so kind of just log in what the patient normally eats throughout the day. And then E is for environmental assessment. So these are factors that affect the ability to purchase, prepare, and consume foods. So again, what's in their community? What do they have access to? Do they have access only to, a Dollar General and a gas station and a McDonald's or something like that? Or is there a good grocery store nearby? Do they have access to fresh foods? Do they have the resources to buy those things too? Because there's, you have to be able to purchase it. And unfortunately, junk food is way cheaper than healthy food. That's definitely a problem. Okay, a little bit on the hormonal effects of food. These are important. So hormones help regulate digestion and absorption to begin with. So you have your digestive hormones like your gastrin and secretin and cholecystokinin and all of that kind of stuff. And then you also have ghrelin and leptin, and these guys play a big role on a person's food intake and stuff. So ghrelin is the hunger hormone. And the more ghrelin you secrete and the more often you secrete it, the more you're going to be driven to eat. You're hungry, drives appetite and stuff. And if that hormone's not kept in check, then a person could just have this insatiable appetite and eating all the time. And there are things that turn off your hunger hormone, and some of those are, for example, eating enough protein. So if a person eats just a lot of carbs or just downs the soda, carbs don't really satisfy, and so the person will be hungry again pretty quickly. And then leptin is another hormone that's involved, and it signals, it's produced by the fat cells, and it signals to your brain how much fat you have stored and how much you can afford to get rid of. And so this one, if your leptin signaling is adequate, then you won't be hungry all the time and stuff like that, and it's more, it will drive you to not overeat and stuff like that. And if leptin signaling is messed up or you have leptin resistance, it could be that your brain is getting the signal from your fat cells that you need to eat more because you have, you know, no fat stored or very little fat stored, when in reality you have like 100 pounds of fat already stored. So leptin signaling can be really important also in weight management. Of course, we got insulin and glucagon also. So insulin lowers blood glucose after a meal. So once a person has eaten and the glucose in that meal has been absorbed from the intestines into the bloodstream, insulin is released so that the glucose can enter the cells and be used for metabolism or storage in the liver or in muscles as glycogen. Glucagon raises blood glucose, so glucagon would kick in when a person is fasting between meals and things like that, overnight, or is skipping a meal. And so the blood glucose is being lowered, and in order to raise it back up to normal, then glucagon will cause the release of glucose from the stored glycogen and so on. It can also cause the creation of glucose from non-carbohydrate sources. And then your macronutrients are your nutrients that are required by the body in large amounts. We're going to look at those. Those are your carbs, proteins, and fats. And then we're also going to look at your micronutrients, which are your vitamins and minerals, but that will be in a different video. All right, start with the proteins. So proteins are broken down into amino acids through digestion. And then those amino acids are used to build the proteins that your body needs. Okay, so this could be muscles, but it also could be antibodies and just transport proteins, albumin, just whatever it is your body needs. The body, however, cannot store protein. The body can store glucose as glycogen and can store fat in our fat cells, but it does not have a mechanism to store protein, so therefore you need a daily intake of protein. And with that, there are 10 essential amino acids and 10 non-essential amino acids. So anything that is essential must be ingested, must be part of your diet in order for you to have them, because your body does not know how to make them. It can make the non-essential ones, but it cannot make the essential ones. And it makes a non-essential from other amino acids. It can just rearrange them and get what it needs. And then you also have an additional protein requirement during growth. So growing children need to eat more protein, or rebuilding. So rebuilding could be, you know, healing from an injury, or it could be healing from being sick. So it's good to have enough protein at that time so that your body can properly, one, fight off an infection if you're sick, and two, rebuild afterwards. The only time a patient might be restricted in protein intake would be in acute liver failure and end-stage renal disease, because the body just lacks the capacity to deal with, you know, high protein intake. So a little bit on biochemical markers for protein. So the ideal protein biomarkers will have a short half-life and will reflect changes in the serum, and those are changes reflecting what is actually going on with protein balance. Markers are affected by protein malnutrition from end-stage liver and renal disease and severe infections and stress injury. So they can go up and down. We're going to talk about how each of these moves. So the first one is albumin. Albumin has a long half-life of 20 days, so that it won't move rapidly. That's what you have to keep in mind. And so albumin can help you identify chronic protein deficiency under conditions of adequate non-protein calorie intake, which is known as kwashiorkor. And so eating enough, but it's non-protein, so it might be a lot of carbs, or maybe, you know, or fats or something like that, but just not enough protein. And this is chronically. So again, it would be more than 20 days, probably months on end, really. It can also help identify caloric insufficiency without protein insufficiency, which is marasmus. And both of those, you would expect albumin to be decreased in the serum. Now, transferrin has a shorter half-life than albumin. It's half of it, so it's about 9 days. Its most important use is as an early indicator of iron deficiency. It's not sensitive enough to really be used as a malnutrition marker. So transferrin levels will go up as iron deficiency increases. So the lower your iron levels, the higher the transferrin is going to be. Next, we have transtheratin. So transtheratin stands for the transport of thyroid and retinol. That's where, because that's what it does. That's where his name come from. It's also sometimes called thyroxine binding prealbumin because it carries thyroxine. Prealbumin has to do with how it migrates on the electrophoresis, and so transtheratin is also often called prealbumin as a test. And transtheratin is actually really the best marker for nutritional response. So it can effectively demonstrate an anabolic response to feeding due to its short half-life, it's only 2 days, and there's only a very small storage pool. So you have very little reserve of transtheratin, and it doesn't hang around for very long. And so it correlates really well with nitrogen balance, going up with intake and going down with deficiency. And so it's a good marker for visceral protein synthesis. So how your viscera or your liver and all that is synthesizing protein in patients that are getting their metabolic or nutritional support. So if they were showing a deficiency and you put them on nutritional support, you should be able to see this transtheratin move pretty quickly in upward direction. Now, retinol binding protein is also related to transtheratin because it is a protein that carries retinol. So retinol is vitamin A. And so vitamin A is actually, because it's a fat-soluble vitamin, is first picked up by retinol binding protein, and then the vitamin A or retinol and retinol binding protein complex is then picked up by transtheratin, and transtheratin is what really ferries it around into the bloodstream. So retinol binding protein is also used in monitoring short-term changes in nutritional status. Its half-life is only 12 hours, and it also has a small pool size. So it moves the same way that transtheratin does. It will go down with deficit in nutritional status and go up as it's being corrected. Insulin growth factor 1, the levels are regulated by growth hormone, so it's a reflection of what growth hormone is doing. So if growth hormone goes up, IGF-1 levels go up in nutritional intake. You have to have an adequate nutritional intake to have adequate growth hormone synthesis. It can be used as nutritional markers in adults and children, and having enough growth hormone, then it would mean that the child is at least building back up and stuff, and that's so it could go up or down depending on what the status is. You would want to see it going up so that the person's adequately rebuilding. Fibronectin is another one. Fibronectin levels decrease after physiologic damage that's caused by severe shock, burns, or infections. It is not usually used as a nutritional marker. Fibronectin is a protein that regulates phagocytosis. And so as these conditions happen, so shock, burns, severe infection, all that kind of stuff, the fibronectin levels could decrease. Nitrogen balance. So it is one of the most widely used indicators of protein change and or adequacy of feeding in a controlled setting. So like if a patient is on, total parenteral nutrition or something like that. And the way nitrogen balance is calculated is the difference between the protein intake and protein excretion. So the protein intake would be assessed by logging all the grams of protein the patient is getting, even if it's via IV or via eating shakes or whatever it is, everything is recorded for 24 hours. And then a 24-hour urine urea nitrogen is measured also. So obviously urea nitrogen from blood urea nitrogen, except this is urine urea nitrogen. Urea nitrogen is the breakdown product of protein, and it's directly related to how much protein metabolism is going on. Then we have the C-reactive protein. This is an acute phase protein. It increases dramatically under conditions of sepsis, inflammation, and infection. And so if it goes, this one goes up, so when there's a lot of stress on the body. And then also high sensitivity CRP is an additional marker for inflammation. It's been applied as a predictor of cardiac disease and other cholesterol-related atherosclerotic diseases. So high sensitivity CRP is basically a marker of chronic low-grade inflammation. And chronic low-grade inflammation is at the root cause of a lot of problems, cardiovascular, but also, obesity. And so high levels of this protein indicate, whether it's the CRP or the high sensitivity CRP, indicates potential problems for the patient. Then the cytokines, so these are interesting. They're not currently done a lot clinically, but they're quite interesting. So there are a complex group of proteins and glycoproteins that can exert a pleiotropic effects on several different target cells. Our interest in these ones are as indicators of low-grade inflammation also. Most nutritional investigation regarding cytokines have been performed on interleukin-1, interleukin-6, and tumor necrosis factor A. As an example, interleukin-6 regulates multiple aspects of metabolism, including glucose disposal, lipolysis, oxidative metabolism, and energy expenditure. And for example, adipose tissue inflammation is associated with diet-induced obesity. So if you have diet-induced obesity, you're probably going to have low-grade inflammation, and it's caused by the presence of this adipose tissue and would cause high levels of interleukin-6 as a marker of inflammation to be floating around in the blood. Total parenteral nutrition is a widely used means of intense nutritional support for patients who are malnourished or in danger of becoming malnourished, especially, for example, think of ventilator patients in ICU and they can't eat and they're on there for days on end, weeks on end. They would need total parenteral nutrition. It is used to administer appropriate amounts of carbohydrates, amino acids, and lipid solutions, as well as electrolytes, vitamins, minerals, and trace elements to the patients. And since it's parenteral, it is IV. So these are given IV to the patient. A lot of times the patient can't eat because of the condition that they're in. A little bit on carbohydrates. So carbohydrates are classified as monosaccharides, disaccharides, oligosaccharides, and polysaccharides. As you eat usually polysaccharides in the forms of breads and pastas and grains, etc., your body would break it down into disaccharides and then into monosaccharides. The monosaccharide of interest for us is going to be glucose. So there are carbs are broken down into glucose for fuel, also fructose, but the glucose is the one that can be used directly for fuel. Fructose can only be handled by the liver and it has to be modified. In that context, again, insulin and glucagon do affect carbohydrate metabolism. Insulin is a storage hormone that's triggered by the presence of glucose. It is also released with excessive calories or excessive amino acid intake. And its insulin drives you to store excess carbohydrates as fat. Glucagon is a mobilization hormone, meaning it can mobilize glucose and release it into the blood sugar when there are low levels, which is usually present during fasting, and it causes the release of stored glycogen and fat, and it is stimulated by the presence of protein. So the carbohydrate markers, but obviously you can do a blood glucose testing. We have a whole video on that. But a little bit on urine glucose testing. So if it's positive, so if you see glycosuria during the early phase of total parenteral nutrition in a small premature infant, it is a signal that the glucose infusion is too rapid. so giving them too much too fast. And if you see glucose in urine of small infants after a glucose tolerance has been established, then it might indicate respiratory disease, sepsis, or cardiovascular changes. So it could be an indicator of stress, something going on with the infant. A little bit on organ function. So the major organ systems need to function properly, obviously, including the liver, because the liver metabolizes all the nutrients, and or the kidneys to excrete all the waste. And you can use various markers such as enzymes and proteins to determine adequate organ function. And so again, you can refer to the videos in the series about the liver, about the kidneys, and all of that to know how to assess each major organ. A little bit on the test to monitor electrolyte disturbances. So obviously you can do serum electrolytes, sodium, potassium, chloride, etc. Sodium regulation can be a problem in children during total parenteral nutrition, so you got to keep an eye on them. Hyperkalemia or high potassium levels is a common problem in children when the blood is obtained by a heel stick, and that would be a pseudo hyperkalemia. So it's not that the infant has too much potassium, it's just that the hemolysis and the stress of squeezing the heel to get the heel stick is causing the hyperkalemia. And then hyperchloremia, metabolic acidosis, is a problem when crystal amino acid solutions are used in total parenteral nutrition. And last few slides going to be on fats. So your dietary fats are cholesterol, triglycerides, and fatty acids. Your essential fatty acids are your omega-6, which is linoleic acid, and omega-3, which is linolenic acid fatty acids. The 3 and the 6 has to do with the position of the double bond. They are both essentially, you need both of them in your diet. Your eicosanoids control the production of hormones and physiologic functions. They have a profound effect at very dilute concentrations, and examples of your eicosanoids are your prostaglandins, your thromboxanes, leukotrienes, and urotoxins. And arachidonic acid, it increases the inflammatory response, it increases vasoconstriction and induces labor. It also activates platelet aggregation and thrombosis. So those are things that can be detrimental to your health. And excess arachidonic acid comes from excess of omega-6 fatty acids, especially from vegetable oils like corn oil, canola oil, and all of that. There's a lot of excess omega-6 fatty acids in the American diet, especially in a lot of the processed foods. It's better to have a higher omega-3 fatty acid content, although you do need omega-6. We tend to have excess of that, and it causes inflammation and, clots and platelet aggregation and vasoconstriction and stuff like that. Dihomogammalinolenic acid, or GGLA, has basically opposite effects to arachidonic acid. It inhibits gastric secretions, it increases vasodilation, and decreases the inflammatory response, and it inhibits platelet aggregation and thrombosis. And lastly, how do you assess lipids? The lipid panel, which has triglycerides, total cholesterol, HDL cholesterol, and HDL and LDL cholesterol at a minimum. Some have more, like VLDL and stuff like that. The two top ones that you're concerned with nutrition is your triglycerides. Ideally, you want them less than 150 milligrams per DL on a fasting sample. Cholesterol, a total cholesterol below 190 is acceptable. Some labs still use 200 milligrams per DL, and so those are two major ones that are assessed. That is your last slide. Thank you.